Good afternoon, everybody. I'd like to welcome you all to our next session of the APDR National Virtual Noon Conference. My name is Dr. Hart Beatty. I'm the chair of the Education Committee for the APDR and the Neuroradiology Fellowship Director at Boston Medical Center. Again, welcome. We're again very excited to have two great speakers speaking about abdominal imaging today. As we do every week, just a few housekeeping items. The session is being recorded and will be hosted on the APDR YouTube channel within a few days' time for a turnaround. The comments and questions are also being recorded through Zoom, and we are muting the microphones of the attendees just to ensure optimal quality for the participants. And we ask that if you have any questions for our speakers that you use the question and answer tool through the Zoom platform, and we will try to answer those questions as we can. I'd like to introduce our two educators for today. Dr. Anu Shenoy-Bhangle from Beth Israel Deaconess Medical Center will be speaking about imaging of cystic hepatobiliary masses. And we also have Kevin Chang, Dr. Kevin Chang from Boston Medical Center, my shop, you know, our colleagues there. And we'll be speaking on virtual colonoscopy or CT colonography today. So without further ado, it's my pleasure to introduce our first speaker, Dr. Shenoy-Bhangle, and ask if you can share your screen. That would be great.
Thank you, Harp. So let's start right away. Good afternoon, everyone. My name is Anu Shenoy-Bhangle, and like Harp said, I'm from Boston as well. I am an abdominal imager with research focus in liver imaging and endometriosis. I shall be discussing cystic hepatobiliary masses today. I have no relevant disclosures. I do have one pertinent disclosure, which is I dedicate this talk to my residents and to all of you who have adapted and demonstrated incredible grit in these hard times. So all of us encounter cystic liver lesions very commonly in our routine work. And there is a wide spectrum of etiologies for these lesions, ranging from simple to confounding lesions. My goal is to show you in a case-based manner how to differentiate benign from the not so benign liver lesions by trying to understand their pathophysiology and what the next step of management might be. So where do these hepatic cysts arise from? If we understand the pathophysiology, it is very simple to remember the etiology and narrow down on the differentials. Now, true hepatic cysts are all lined by biliary epithelium and are developmental or congenital. Some of these, even though they are developmental, may not be present at birth, but continue to grow throughout life and manifest later. These include the entire list on the box on my left-hand side here, except for peribiliary cysts and ciliated foregut duplication cysts, which are not lined by biliary epithelium, and I shall elaborate on these more later. All other cystic lesions in the liver are pretty much acquired. They may be acquired due to infections traveling to the liver via portal venous drainage or other routes. Then there are malignancies that are primary to the liver or metastases. They may be acquired secondary to liver injury or liver surgery. And finally, a very important point to remember these days is, and this group of cystic liver lesions or cystic masses, so to speak, may be encountered in liver tumor centers with an interventional radiology setup. And not to forget, we do a lot of locoregional therapy for HCC treatment these days. So some of the cystic liver masses may present secondary to this treatment. Now, to understand this entire concept better, I want to digress a little and bring you back to our embryology days. This is a pictorial representation of a single hepatic lobule on the right-hand side. And the hepatic lobule, as you all might well know, is comprised of sheets of hepatocytes and a portal venous triad. Now notice how in this portal triad, the portal vein is very close to the bile duct. And this relationship of the bile duct and portal vein starts developing very early in the embryonic life from the 12th week of gestation, where a sheet of biliary epithelium, which is represented in green here, wraps snugly around the portal venous radicle. Bile ducts, in very simple terms, bile ducts are normally formed from remodeling and partial involution of these cylindrical ductal plates surrounding the portal venous radicals. So there is a terminology called ductal plate malformations, which pretty much is responsible for giving rise to a lot of bile epithelium or biliary epithelium lined hepatic cysts. So let's look at this image right here. Now, when the biliary tree develops, the larger bile ducts are towards the porta hepatis and they branch out towards the periphery of the liver. So if development is hampered at the bigger branches, the process results in choledochal cyst formation. If the process is arrested at the medium-sized ducts, that develops or that can give rise to polycystic liver disease. And finally, if the process is arrested at the periphery or the outer third of the bile ducts in the liver, that pretty much can give rise to biliary hamartomas. And we shall see great examples of these cases subsequently. Let's start with simple things first. We are all familiar with this simple hepatic cyst, which appears very sharply demarcated, anechoic on ultrasound, and no complex internal echoes or contents. On contrast-enhanced CT, again, very sharply demarcated, no internal enhancing septations or nodules, and the CT Hounsfield unit pretty much should range from 0 to 20 Hounsfield units. On MR, these are hyper-intense on T2 weighted images, hypo-intense on T1 weighted images, and a simple hepatic cyst should not show any enhancement on the post-contrast studies. Since this talk is case-based, here is our next patient. This is a 55-year-old gentleman with a history of cirrhosis. On this coronal non-enhanced CT, you see two types of hypodensities in the liver, some that are small and in the periphery, and some, well, I'm not sure if these are cysts or what is going on. However, if you look at the coronal T2 MR, you can clearly see small, rounded T2 hyperintense cystic lesions throughout the periphery of the liver, as well as what looks like surrounding the central portion of the liver. And here on the contrast-enhanced axial study, you can see that these do not enhance. If we zoom in, you notice that there is almost a pearl of string appearance of multiple tiny cysts on both sides of the bile ducts and the expected location of the bile ducts and the portal venous radicals. So this appearance here is a beautiful representation for peribiliary cysts. And just going back, these distributed in the outer third of the liver are pretty much biliary hamartomas. So biliary hamartomas are they also go by the name of von Meyenberg complex. They are typically dilated small bile ducts, outer third of the liver, less than 1.5 centimeters. They have no communication to the biliary tree and they are pretty much asymptomatic, while the peribiliary cysts are dilated peribiliary glands, and therefore you find them around the central bile ducts. Now, why do these peribiliary glands dilate? So if you think about it, these are commonly seen in patients with portal hypertension or autosomal dominant polycystic liver disease, where due to some reason, if the portal pressure goes up, then the necks of these peribiliary glands get occluded and they dilate. One mustn't mistake them for intrahepatic bile duct dilation. The way to distinguish them is these are seen on both sides of the dilated bile ducts, and periportal edema as well. The periportal edema is linear. These are cystic in nature. So the take-home points for biliary hamartomas and peribiliary cysts include these do not have any clinical significance. It is therefore very essential to recognize them and dismiss them subsequently. They do not communicate with bile ducts. Again, do not mistake these for intrahepatic dilated bile ducts. This is a 34-year-old lady presenting with right upper quadrant pain. As you can see here, ultrasound image shows a dilated hypoechoic mass with anechoic areas within it, no vascularity, and it pretty much has a tail-like projection extending towards the central portion of the liver. Here are 4 MR images, and on these MR images, you see a cystic structure, hypo-intense on T1, hyper-intense on T2, with no enhancement. Of course, there is some enhancement of the surrounding liver parenchyma and maybe some biliary ductal dilation. In the coronal plane, this is what the cystic lesion looks like. The moment you see a tail-like extension from a hepatic cyst extending towards the porta, there is one thing that should strike you, and that is a choledochal cyst. This is the ERCP on this lady. you can see that there is some contrast going into the right-sided hepatic duct, and there is a mass effect. And on a subsequent image, there is contrast that spills freely into the cystic hepatic lesion. So these choledochal cysts are congenital segmental dilatation of bile ducts. There is this classification that most of us are familiar with, the Torani classification, where they classify it into 5 types. The thing to remember about these is choledochal cysts communicate with the biliary tree and therefore that ERCP appearance. MRCP with EOVIST, which is a hepatobiliary agent, is a good technique to demonstrate the communication with the bile ducts, and ERCP, of course, which is more invasive. Now, the take-home points of why we need to identify choledochal cysts correctly are, besides complications that they may be prone to, meaning development of calculi, presentation with recurrent cholangitis, pancreatitis, in up to 30%, there is an increased incidence of development of cholangiocarcinoma. And that is the importance of correctly recognizing choledochal cysts. And oftentimes, these are subjected to surgical excision. Moving on, here is a young male presenting with right upper quadrant pain. Again, ultrasound images demonstrate oblong, ovoid, anechoic structures with an eccentric dot of increased echogenicity. This is one of the most beautiful cases of Caroli's disease that I want to share with you. On the axial T2 weighted images, you can see dilated T2 hyperintense cystic structures pretty much distributed throughout the liver in the mid portion of the liver. And as you recollect, if you go back to the embryology slide that I showed you, when the medium-sized ducts are abnormally developed, this is what Caroli's disease presents as. On the contrast enhanced study, there is what you might say, what people call a central dot sign. I like to call it an eccentric dot sign. And what that eccentric dot represents is an enhanced portal vein radical. And again, this relationship of the eccentric dot, which is a portal venous radical, and the surrounding abnormally developed dilated bile ducts, again goes back to the embryologic relationship of the bile duct developing around portal veins. Now, 2 years later, this young gentleman presented with this mass, which was a cholangiocarcinoma. So Caroli's disease, of course, in 1958, Jacques Caroli first described this rare congenital entity, where he found that there was non-obstructive saccular dilation of large intrahepatic bile ducts. And more important for us is to recognize Caroli syndrome, which is a more common variable in which the dilated bile ducts are associated with congenital hepatic fibrosis. So we just saw what a central dot, or more like eccentric dot sign, as I like to call it, represents. And the important points to recognize for this disease entity, again, besides complications in the form of recurrent cholangitis, the important thing is they can present in up to 7% of patients with cholangiocarcinoma. Again, important to know Caroli syndrome, which is hepatic fibrosis with Caroli disease. These patients, this disease entity can either be segmental or diffuse. If it is segmental, surgical excision is an option for them. And liver transplantation is something we can also offer them. This is an entity that all of you are very familiar with. 30-year-old presenting with right upper quadrant pain. Notice how the liver is huge and enlarged, secondary to formation of multiple T2 hyperintense non-enhancing cysts within it. These cysts can undergo hemorrhage, as you can see here. This is an axial T1 weighted image before contrast that demonstrates intrinsic T1 hyperintense signal layering within it, suggestive of intracystic hemorrhage. Again, this is a spectrum of fibropolycystic liver and can be associated with renal involvement as well. Oftentimes, the autosomal dominant polycystic liver disease coexists with other ductal plate malformations. The thing to remember about this entity is these patients often develop progressive liver failure. MR is good to see, to look for complications. And again, if these cysts become large, cause pain, or get secondarily infected, percutaneous decompression for symptom relief is an option that we can offer them. And liver transplantation also is on the cards for this group of people. Here is the next very interesting case, 43-year-old male, incidental finding on an ultrasound within the liver. The ultrasound was performed for something else. What do you see here? I don't know what to make of this lesion. There are some tiny anechoic cystic structures, and there is dense posterior acoustic shadowing, almost like calculi, but these echogenic structures here are not bright enough. So sure enough, we did an MRI to figure out what is going on. And this is what that lesion looks like on MR. This is a solitary lesion. It almost seems to have multiple serpiginous T2 hyperintense structures compacted together. On the pre-contrast T1 weighted images, there is no enhancement within the hypointense tubular structures, and on the post-contrast, the septations enhance within it. This is what it looks like on gross morphology, gross pathology, and this description is called a honeycomb appearance, if you can imagine it. So this entity is a multicystic biliary hamartoma. These are rare hamartomatous nodules, and these are also thought to be a manifestation of ductal plate malformations. Typically, they are asymptomatic and benign, and they develop close to the liver capsule or close to the falciform ligament. Important to recognize these as they are asymptomatic. Again, because they are rare, if we recognize them correctly, we avoid biopsy or additional follow-up or evaluation. The only exceptions to the rule when they would be surgically excised if they continue to enlarge. Moving on, this is an ant mini. On the axial and coronal sagittal post-contrast CT images, we see a single solitary, almost subcapsular, simple appearing cystic lesion in the region of segment 4. Sure, this is an ant mini. This is a ciliated hepatic foregut duplication cyst. This is not a true cyst because it is not lined by biliary epithelium. In fact, it is formed when due to ectopic location of embryonic foregut cysts in this location. And therefore, very commonly, these are subcapsular because during embryonic development, a small amount of embryonic foregut tissue left remains behind on the along the liver capsule at the dome, typically segment 4, 5, or 8. These are good to recognize. They are asymptomatic, leave alone lesions. Very rarely, and I have yet to see a case, it is said that they can develop squamous cell carcinoma within it because of the lining, which is different from biliary epithelium. Again, if they become large, percutaneous decompression for symptom relief is an option. So now changing gears, this is a nice podcast for the podcast lovers. Let's talk about acquired cysts. If something doesn't fit the bill and something doesn't look like all differentials I have shown you so far, there is a diagnostic checklist that I love to adhere to. And when I encounter these cystic hepatobiliary lesions that do not look simple or do not follow a typical pattern, I ask myself, what is the history? Has this patient been subjected to some traumatic experience? Any history of recent surgery of the liver or liver-directed treatment? Is there a known primary? Is this patient presenting with infection in the form of fever, elevated white counts? Patient demographics is important, and history of travel. So let's look at these acquired cystic liver lesions. Here is a gentleman admitted with sepsis. Ultrasound is the first investigation, shows a very complex hepatic mass with some anechoic cystic areas within it. He had a markedly elevated creatinine, was in the ICU. This is a patient I treated on call one weekend. So he could get only non-contrast CT, where you see a vague hypodense lesion in the liver in segment 7. For some reason, he did get an MRI as well. Good for us, learning. And here on the non-contrast MR, on the coronal T2 weighted images, you see a T2 hyperintense or mixed signal intensity lesion. We don't have contrast. There's almost like a spoke wheel pattern here. There is maybe some restricted diffusion. There are some areas that are dark on the ADC here. Looking into his entire pan scan, this gentleman had an area of pneumonia in the lungs, and sure enough, we aspirated it. This turned out to be a pyogenic liver abscess. So there are many reasons for development of a liver abscess. Common etiologies in adults include Klebsiella pneumoniae. Again, the routes of infection may be portal or biliary, penetrating injuries or iatrogenic. Some typical appearances or textbook descriptors for these liver abscesses, single large abscesses, include a cluster sign or a target sign where there is layered enhancement of the hepatic parenchyma surrounding the infection and trying to control it. MRI may show restricted diffusion if the abscess has liquefied. And again, the take-home points is sometimes solitary liver abscesses in development can be very difficult to pinpoint. Of course, there has to be a clinical setup where the patient has fever, elevated white counts. When in doubt, aspirate. the imaging that I just showed you was complex, but given his clinical picture, we went ahead, aspirated, we got pus in our needle and therefore left a drain there, and he did very well subsequently. So percutaneous drainage is an option, but it has a failure rate of up to 8.4%. Surgical drainage is an option. This is another lady presenting with vague abdominal pain, again on ultrasound. We don't have color Doppler here, but on the gray scale, you can see that there is a very heterogeneous looking mass. Just looking at this, it almost looks like it is solid. These are her MR pictures. Of course, I have to show you a hydatid cyst today. And this is a beautiful example of multiple hepatic hydatid cysts. There is one in the spleen as well. And this is a very classic look for a hydatid, where you have these delicate membranes within the T2 hyperintense cyst. This is a classic look for a hydatid cyst. Sometimes there can be fat globules floating within the hydatid cyst when there is leak of the daughter cyst, so to speak. And here is a gross picture of a hydatid. This is just from literature, just to show you how peritoneal hydatidosis can look not so pretty. So we all are familiar with this entity. The humans are intermediate hosts, and the way to recognize these is by presence of daughter cysts. Various signs have been attributed to this imaging finding: drooping lily sign, floating membrane sign. Again, important to recognize this entity, as hydatids may rupture into biliary epithelium or peritoneum and may cause anaphylaxis. So the take-home points to recognize a hydatid cyst include recognition of the peri-ecto and endocysts. Percutaneous drainage is an option in highly endemic areas with anesthesia standby. There are various things that have been instilled into these cysts, including hypertonic saline, and surgical excision is always an option. Moving on, here is a 54-year-old lady presenting with fever and abdominal pain. This is an interesting entity, and you notice how there are vague ovoid cystic areas throughout the liver. This picture here is important. There are some T2 hypointense membranous structures on the surface of the liver. This entity is Hepatic Fasciola, where humans are the intermediate hosts. Man ingests watercress, freshwater plants, and the larvae exist in the stomach, penetrate the duodenum, peritoneum, and this is a very unique way of transmission where the larvae penetrate the liver capsule, and that gives rise to this imaging appearance. And subsequently, their ultimate destination is the bile ducts. They transgress the hepatic parenchyma, reach the bile ducts, and reside there. Again, a high index of suspicion, that typical imaging appearance that I showed you with membranes on the liver surface, and an acute cholangitis-like picture is your point to the diagnosis. Here is another male with right upper quadrant pain. On the MR, on the T2-weighted images, there is an intermediate T2 hyperintense signal lesion with what looks like thin septations within it. On coronal T1 pre-contrast CT, this almost looks like a large hypodense mass within the liver. On post-contrast delayed images, there is peripheral enhancement of this lesion with gradual filling in, and this is a classic look for a giant cavernous hemangioma. Unless, so one of the take-home, this is a classic appearance, I need not teach you, but one of the take-home points for recognizing and making the correct diagnosis for cavernous hemangiomas. Recently, we had a patient present with a non-contrast CT, this appearance, and severe right upper quadrant pain. The patient also had fever. MR demonstrated this classic appearance, so do not mistake these for abscesses. Can they get secondarily infected? Theoretically, yes, but I've hardly seen a cavernous hemangioma turn into an abscess. If these are large, causing pain and discomfort, they can be surgically excised. Here is another lady with upper abdominal pain. As you can see, there is a large cystic structure in the left lobe of the liver. There are some thin enhancing septations. Another patient with a slightly more complex appearing T2 hyperintense non-enhancing mass with some hemorrhage within it. This entity is called a mucinous cystic neoplasm, classified into two types, non-invasive and invasive. Previously, this was called cystadenoma or cystadenocarcinoma, and WHO revised this terminology. We now call it mucinous cystic neoplasms. The demographic is very classic. Females, these are located in the central liver. Again, similar to the ciliated foregut duplication cysts, these are endodermal immature stromal cells that are left behind on the liver capsule during embryogenesis. And so these cysts are lined by columnar epithelium. A lot of them in their subepithelial layer have ovarian-like stroma, which can develop into a malignancy. These do not cause biliary duct dilation. That is one of the typical features about these, and they do not communicate freely with the bile ducts. Moving on, here is a 74-year-old male with unintentional weight loss. Notice how on this non-enhanced CT, you see almost a hypodense, not exactly cystic, but a hypodense mass in the left lobe. On MR, it is hyperintense on T2 and shows rim enhancement on the axial T1 post-contrast images. Do not mistake this for an abscess. This is a peripheral mass-forming cholangiocarcinoma. I'll show you a few more examples and then we'll look at neoplastic etiologies in the liver. So again, this is an ultrasound image of a complex anechoic lesion with septations within it. This is what it looked like on a contrast-enhanced CT. These were treated metastases from neuroendocrine tumor. Again, these are multiple liver lesions. They show some heterogeneous enhancement in the center, a little bit of restricted diffusion with T2 dark signal on the ADC maps. A few months later, these increased in size, and these were metastases from jejunal adenocarcinoma. As you can see here, this is a few months later, where the malignancy just blew up. So the take home here is, do not mistake lesions that may look like cysts for simple, multiple cysts in the liver. Always keep in mind cystic metastases. When they have slightly irregular margins and they look gray, they fade into the liver. These, when they do not have sharply demarcated margins. Keep in mind that these may be cystic liver metastases. Here is another gentleman, large rim-enhancing lesion in the liver. He presented with an epigastric bulge. He also had fever. He had a clinical picture like an abscess. However, there was something not right about this entire thing being an abscess, in the sense, even though he had fever and epigastric pain, he did not have elevated white counts. We biopsied the rim of this lesion. It turned out to be neuroendocrine metastases from a pancreatic primary. This is a lady who had a known pelvic mass presenting a few months later with this appearance. Axial contrast-enhanced CT of the liver looks like there is a large cystic lesion here, another one posteriorly, but look at the coronal sagittal reformats. This is a lesion that is sitting outside the liver, indenting on the liver surface. These were peritoneal metastases from Mullerian carcinoma. So cystic metastases, when you have multiple lesions, some atypical feature, like I mentioned earlier about their margins, think of cystic metastases. The common cystic mets to the liver include neuroendocrine tumors, GIST, lung adenocarcinoma, colorectal. So there is a long list, and therefore it is important to keep in mind that not all cystic looking lesions in the liver may be simple cysts. Let me wrap up quickly by showing you the last few cases. This is a 62-year-old lady presenting with a palpable epigastric mass. This looks like a simple cyst in the liver. When we dug into her history, she had a gallbladder, she had a recent history of cholecystectomy, and indeed what this was a resolving hematoma that went silent, grew in size, and then she presented straight with that epigastric mass. Here is a 64-year-old gentleman presenting to the ER with right upper quadrant pain. The first gut instinct was to think that this is an abscess, but digging deep into his history, he had had an RF ablation just 2 days ago. And that is something to remember. With locoregional therapy, patients, especially after microwave ablation or radiofrequency ablation to hepatic lesions, they can present with some amount of air within these treated cavities. A small amount is acceptable. However, this large amount, even if it is shortly after presentation, again, may truly be an abscess. So beware of that entity. Finally, let's wrap up by looking at what we have learned in this half hour. Once you know the pathophysiology, it becomes easier to narrow the differential. So true cystic disease in the liver oftentimes has biliary epithelium. All the rest are acquired, or always rather I should say, has biliary epithelium lining them. All the others are acquired. When you see segment 4, solitary cystic lesions, think of ciliated foregut duplication cysts or mucinous cystic neoplasms. And the theory here is implant theory, not de novo development in the liver. Peribiliary cysts are often seen in patients with increased portal pressure and blockage of the neck of peribiliary glands. History of liver surgery or liver-directed therapy is very important. Benign lesions, whenever you see thin wall, no enhancing septations or nodules, think of benign lesions. The exception to the rule being the multicystic biliary hamartoma. And not so benign lesions will present with mural nodularity, thick septae, ragged inner surface, typical enhancement pattern within the solid portion of the lesion. With that, I'm going to wrap up here, and please feel free to send me questions on the Q&A portal. I thank you all for your attention.
Thank you so much, Anu. We really, really appreciate that great talk. As you mentioned, we're going to transition over to Dr. Chang, and I see that he's sharing his screen already. So invite you to present your talk. Thank you.
Today I'm going to be talking about one of my favorite topics. That's virtual colonoscopy, or CT colonography. You know, it says here I'm the director of MRI at Boston University right now, but in a fairly recent previous life, I was director of CT at Newton Wellesley Hospital and part of the MGH Brigham system in Boston. And then before that at Brown University, I was the director of the CT colonography service line there at Rhode Island Hospital, Miriam Hospital, and the Rhode Island Medical Imaging private practice. So I don't have any financial disclosures, but I do have a relevant personal disclosure in that I have very personal experience with CT colonography, not just starting up and running the service line in multiple locations, but about 4 months ago, I had my own CT colonography because I had turned 45, and the American Cancer Society now recommends screening starting at the age of 45. I also had a family history of colon cancer in 2 first-degree relatives. So I had that procedure in January, and it ended up being positive for something, and I will show you the study at the end of the talk. So that's my personal disclosure. I also have friends that have been diagnosed, same age as me, with stage 4 colon cancer. So I know that there's definitely there's an increasing incidence of colorectal cancer in the younger patient population. So today, we're going to be talking about about colorectal cancer and why we should be screening for it. We're going to identify the targets of screening and provide the rationale for a selective polypectomy approach, which is what we advocate when we're reading CT colons. And then we're going to compare CT colonography with the other screening options. So the basics first: colorectal cancers, when both sexes are combined, is the second leading cause of cancer death in this country, responsible for 1 in 11 deaths. There's 148,000 new cases every year. All of us, despite whether we have risk factors or not, have about a 5% lifetime risk of developing colorectal cancer. So it's not a controversial test to be screened for. But the good news behind that is that since screening options have been taken up more rigorously over the last few decades, there has been a decreasing overall incidence and mortality of colorectal cancer, and that's directly attributable to increased screening. But the downside for that is that because colorectal cancer is a preventable disease, screening should be done by everybody, but only 50 to 60% of eligible adults are currently getting screened, and half of those that are getting screened are getting it done by colonoscopy. So the other half of those that are getting screened are using stool tests, fecal occult blood tests, other screening tests that are not great at prevention, but certainly better than nothing for detection. The flip side to that is that in the age group that's under 50, that is those that were traditionally not in the screening age population, there's been a dramatic increase in the incidence of colorectal cancer since the 90s. And people aren't completely sure what the reasons for that are. Certainly the thought is that it's multifactorial. It could be related to changes in diet, changes in the environment, increasing incidences of obesity. There's multiple possible explanations, but the underlying pathophysiology to colorectal cancers is most cancers, about 95% of cancers, follow one of these two cancer progression pathways. And the commonality between these two pathways are that it usually involves a whole cascade of mutations that pile up on top of each other and are involved in the transition between hyperproliferation of the epithelium to an adenoma to an outright invasive colon cancer. And this development takes on the order of 10 to 15 years, maybe even longer for this rated adenoma sequence. So certainly there's a long window for the possibility of prevention before you even develop colon cancer. And then once you have colon cancer, there's a shorter window for cure. So this long lead time it makes colorectal cancer an optimal cancer to try to screen for, as well as prevent, especially if you can pick up these precursor lesions that are polyps, adenomatous polyps. We do know from the literature, as well as from a long experience with colorectal cancer, that earlier the detection of polyps, the lower the incidence and mortality of colorectal cancer. So this is not even this is not up for debate. And because of the long lead time, colorectal cancer screening really truly represents a true primary prevention modality, and the removal of polyp definitely has been shown to preclude the further development of cancer. In terms of cancer, once cancer develops, the earlier the diagnosis is made, the better the prognosis is as well. So certainly, the earlier you want to detect these, the better your 5-year survival. So our target population is basically those that are either 50 or 45 and older, depending on which society guidelines you follow. And that's for any average risk individual, as well as those that are at increased risk, those with either a family history of colorectal cancer or a personal history of polyps or cancer. And the recommendation there is to either start at the age of 40 or 10 years before the youngest index case in your family history. Those that are at high risk, particularly high risk, those would be patients with inflammatory bowel disease or a hereditary syndrome. Those patients should still go on to optical colonoscopy as their first-line modality because of the high incidence of biopsies. In fact, inflammatory bowel disease patients are probably going to be getting random biopsies at the time of colonoscopy. So those patients should still go on to colonoscopy for their first choice screening. But the others, these are the ones that can be presented with a whole menu of multiple options. And I think most people do believe that the more options that you do offer nowadays, the increased rate of adoption of screening in the general population. People like to be given some degree of choice. The American Cancer Society last updated their recommended screening options in 2018, and the big change in the latest guidelines was that they lowered the threshold for screening of average risk individuals from 50 to 45, and that's because of directly as a response to the increased incidence of colorectal cancer in the younger age population. And they divided their tests into two broad categories: those that detect polyps or tested prevention, also known as structural tests, and then those that detect outright cancer. And these are typically your stool-based tests, such as alcohol blood testing, immunochemical testing, and stool DNA testing. And they also took double contrast bearing animals off the list because largely in places that do CT colonography, that has completely replaced double contrast bearing animals. So double contrast bearing animals really are not as good as CT colonography in the detection of polyps or cancer. The U.S. Preventive Services Task Force updated their recommendations in 2016, and rather than trying to pick and choose between specific tests, they decided that any screening was highly recommended and was given a grade A up to the age of 75. With patients that are older than 75, made the decision being more of an individual one, based off largely the patient's estimated age of how long they're expected to live beyond the age of 75. Because basically, colonoscopy and CT colonography, if you have a 10 to 15 year lead time in terms of the detection of polyps, you want to make sure that the patients have 10 to 15 years of expected life left to get a benefit to screen. And similarly, they divided their tests into the direct visualization tests and the stool-based tests as well, very similar recommendations. So usually when the U.S. Preventive Services Task Force approves and gives a grade A or B to a screening exam, CMS, the group that controls Medicare and Medicaid coverage, is supposed to cover all those tests without additional cost. And at the moment, they do that for all the tests except for CT colonography. And if you remember, in 2016, there was a change in the administration of our government as well, and they were not yet interested in revisiting the question of whether CT colonography should be covered or not. So hopefully that will change at some point in the near future. But until then, right now, Medicare and Medicaid patients can get CT colonography if they had an incomplete colonoscopy for any reason except for an inadequate prep if it's being scheduled on the same day, or for contraindication of colonoscopy. And the indication of that can be pretty broad, either patients that are on anticoagulation that they prefer not to discontinue, difficulties with prior colonoscopy, or difficulties or high risks for sedation. Even patients that have had prior surgeries such as hysterectomies and whatnot might be a good candidate for colonoscopy because of changes in the anatomy in the pelvis. The good news is that patients that have private insurance, most of the private insurers, including the big five, are all covering CT colonography for screening purposes. So that's one of the best kept secrets in medicine right now, is that CTC is covered for most patients with private insurance. And a lot of that depends on which state you're in as well. The screening performance between these different tests can vary. The good news is that they're all pretty decent at cancer detection. Certainly the structural tests are better than the stool-based tests. But where they significantly differ is in their sensitivity for polyp detection. Certainly the structural tests, CT colonography and colonoscopy, are both statistically equivalent in terms of the detection of clinically relevant polyps. Those are 6 millimeters and larger in size. Whereas the stool-based tests are not as good at polyp detection. In terms of polyps, as other things in life, size does matter. And the larger the polyps are, the higher the risk of cancer or risk of adenomas, particularly high-grade adenomas. But as you can see in these terms of polyp sizes, this extremely diminutive size range, those that are less than 5 millimeters in size, have a less than 1% risk of cancer in 10 years, and basically almost 0% risk of cancer in that polyp now. And from what we know of the natural history of polyps, only 3% of adenomas really develop into cancer. So some polyps come, some polyps go. They're a waxing and waning phenomenon with only a very small minority developing into cancer. So in a retrospective review of pathology in 3,744 of the polyps in the 1 to 5 millimeter size range, only one had advanced adenoma and none of them had cancer. So for our purposes, I don't care about polyps that are 5 millimeters or smaller in size, especially if you're following the recommended screening intervals for these exams, because a single test is not sufficient for a screening regimen. You need to repeat these tests at your either annual, every 5-year, or every 10-year interval, depending on the test. If there was a diminutive polyp that was increasing in size, you should have more than enough time to catch that in time before it becomes an invasive cancer. So we're going to concentrate on our 6 millimeter and larger size categories. And to account for that, in CTC, we've developed the CRAD system. This was developed in 2005. This was a second RAD system after BI-RADS, before RADS really became as fashionable as it is today with all the different RAD systems. CRADS was the second out of the gate. And back then, and it stood the test of time 15 years later, we're still following the same 4 categories, C1 through C4. C1 being normal or benign findings such as lipomas, and then C2, 3, and 4 directly related to the size or the multiplicity of polyp findings. And we've tried to differentiate 1 or 2 sub-centimeter polyps from 3 or more subcentimeter polyps or a polyp 1 centimeter or larger in size. And our recommendations for the 1 or 2 subcentimeter polyp ranges either offering a 3-year follow-up screening, whether that's CTC or optical colonoscopy, or consideration of follow-up colonoscopic polypectomy if somebody can't live with the knowledge that they might have some subcentimeter polyps that are being left unresected. And then those with 3 or more subcentimeter polyps, or a polyp that's a centimeter or larger in size, which comprises about 8 to 12% of CT colonographies overall. Those patients being directed onto colonoscopic polypectomy for treatment and ultimate prevention. And then the C4 categories for outright masses, which can either go on to colonoscopic biopsy and surgical consultation. So those categories were developed 15 years ago with not a lot of data to back them up. But in the 15 years since then, there have been multiple populations that have been looked at retrospectively in terms of what happens to those C2 categories. You know, is it really truly safe to leave those polyps for another day? And in the 2 largest series to date, both have shown pretty similar natural histories for polyps, and about a quarter to a third have been shown to progress, whereas a third to a half have been shown to be stable, and then the remainder either regressing or even completely resolving. So certainly this, I think, does show that the proposed management from the CRADS system is certainly warranted. Furthermore, the reason why we want to be a little bit more selective about these polypectomies is that optical colonoscopy certainly does have its share of complications. For the most part, they're pretty rare, and the risk of perforation has been documented to be about 0.1 to 0.2%, so it's certainly very low. Risk of death even lower than that. And the risk of bleeding and overfixation are also complications that don't get as much attention as they might deserve, with 0.5% each. But another one that I want people to be aware of is that just in terms of hospitalization within 7 days or within 30 days of a colonoscopy is not a small rate. It can be as high as 3.8% in some community hospitals. So certainly you don't have to perforate to have an issue with colonoscopy. A lot of these patients will complain of pain. They can get a post-polypectomy syndrome. There are certainly issues that come with invasive procedures such as colonoscopies. Whereas the complication rate for CT colonography largely comes from those that are being referred to colonoscopy and the risks associated with that. So that raises the comparison between the screening paradigm between optical colonoscopy and CT colonography. Basically, optical colonoscopy has long held that universal polypectomy should be the standard of practice. It's interesting to see that some colonoscopists are starting to believe that they can ignore these 5 millimeter or smaller polyps, either leaving them alone or resecting and discarding and not even sending those lesions to pathology. And so certainly there are GI docs that are well aware of the exceedingly low risk of finding significant pathology in those diminutive polyps. But for CT colonography, because we're trying to limit the number of patients we send on to colonoscopy, we'd like to be a little bit more selective. So this is more like a sniper gun rather than a machine gun. And certainly the choice of your screening paradigm affects your potential for complications and the amount of resources utilized. In terms of performance, this is one of my favorite papers from Drs. Kim and Picard and that group from Wisconsin, where they had 2 arms of patients, so over 3,000 patients in the primary CT colonography arm and over 3,000 patients in the primary optical colonoscopy arm. And they only referred about 8% of their patients to optical colonoscopy for a polypectomy. And with about only a fifth of the number of polyps removed, they're able to show equivalent yield of advanced neoplasia. They were able to detect even more cancers in the CTC arm than the optical colonoscopy arm. And then, not to be ignored, the perforation rate was 0 in the CT arm and 7 in the optical colonoscopy arm. So this validates the selective polypectomy paradigm of CT colonography. The other half of the CRAD system is the categorization of extracolonic findings, and this really preceded all the ACR white papers, which would probably give you better guidance as to what to do with incidental findings that you see in CT, because we do see findings outside of the colon as well, even on these low radiation dose exams. And we try to categorize the relevance of the incidental findings, because a lot of the incidental findings, most of the incidental findings that we see on CT are not clinically relevant. And that's not always adequate. That's not always accurately reflected in the literature. A lot of the gastroenterologists talk about the high incidence of incidental findings and how this is a downside to using CT for screening. But only about 10 to 15% of the incidental findings that we do find outside of the colon really might warrant some kind of a follow-up. And a lot of this is related to local practice patterns and patient preference. And then those that we do deem to be very clinically relevant, we would put in the E4 category, and that might warrant a discussion with the referrer as well. So really quick, in terms of the actual procedure itself, it's not rocket science anymore. I don't even consider it advanced imaging. Any CT scanner these days can pretty much do this adequately. If you've got more than 16 detectors, your scanner is good enough for CT colonography. It's a fast breath held, low radiation dose helical CT in the supine and prone positions, or in 2 different positions. It doesn't have to be supine and prone. And the colon needs to be prepped and inflated. And the way we do that is through bowel preparation. So we're not avoiding a bowel prep, but I think I've streamlined our bowel prep to be much more straightforward than most colonoscopy bowel preps. We have our patients stay on a clear liquid diet for 24 hours. And then in terms of the prep itself, 2 10-ounce bottles of magnesium citrate are all you need. These are like $2 or $3 from over the counter from your local pharmacy. And then 4 5-milligram bisacodyl tablets as an adjunct to the colonic cleansing. In addition, what's more specific to CT is that we'd like to tag any residual fluid or stool that may still remain in the colon. And you can do this, most centers will do this with iodinated contrast, oral iodinated contrast, and some will also add barium as well. And I'll tell you the reason for that in a couple slides. We can do this on the same day basis as well for patients that have had an incomplete colonoscopy, for example. You can do this in as short as 2 hours if you give diatrozoate, basically what we call gastrographin or gastroview. And in 2 hours, it does reach at least the descending colon in about 3/4 of patients. So the alternative for an incomplete colonoscopy is we can re-prep and schedule for a different day. The reason why we like to tag is if there are any polyps that are submerged under the fluid, if you don't tag the fluid with contrast material, you're not going to be able to differentiate the polyp from the adjacent fluid. There's not enough of an attenuation difference between the two. And this is an example of a polyp on a fold that's submerged in both positions, supine and prone, and we would not have picked this up without tagging. The other potential benefit to tagging is that the barium and possibly the iodinated contrast as well can adhere to certain kinds of polyps, particularly flat lesions. And these are the ones that have been traditionally thought of as being more difficult for CT to pick up. It's also more difficult for optical colonoscopy to pick up, but the contrast agent has been shown to coat these lesions and help you detect it, particularly on the 2D images. And these are 2 examples of sessile lesions and flat lesions that are aided by the adherence of the tagging material to them. The other part of getting the colon ready for CTC is an insufflation, and most places that do a fair volume of CTC should be doing this on an automated basis with an automated CO2 insufflator. And these are really easy to use. You basically just plug in one end to the machine, plug in the business end to the patient, and you insufflate. And it starts up very slowly, ramps up to a certain pressure level. It has a lot of fail-safes in terms of venting off if the pressure gets too high. It's very easily tolerated and much more comfortable than room air. Although you can use a double contrast barium enema setup to do this with manual insufflation of air as well. And that's how we started originally when we were getting the service set up to try to prove a business case for the purchase of an insufflator later on. And then the scan is a low radiation dose scan in 2 positions, and you don't need IV contrast for these, although you can use IV contrast if there's a known obstructing mass, for example. The dose is reduced with automatic tube current modulation. Most scanners nowadays have iterative reconstruction as well to reduce the radiation dose, and the typical doses are now on the level of annual background radiation exposure. It's a fraction of a routine happening in public CT, even though it's 2 different scans. And it's the key is that it's also lower radiation dose than a double contrast bearing enema. The risk of radiation in this particular patient population is pretty debatable. I would say, if you look at the risks of the theoretical risks of cancer induction in relation to age, it really drops off after the age of 35. So I wouldn't even consider radiation to be a particular risk in this patient population. Other than lower risk to perforation, keep in mind that other differences from colonoscopy include the lack of sedation. So patients can immediately return to activity. They do not need a family member or a friend to drive them home after they recover from sedation and colonoscopy. Less manpower is utilized. The exam is faster, and patients that have had both exams do prefer CT colonography over optical colonoscopy for the most part. But you still need colonoscopy for biopsy, and that happens in about 1 in 10 studies. And it does not avoid a bowel prep in general. So as you can see, some of these have implications in our post-peak COVID ramp-up of outpatient operations. You can see how CTC might play a potential role in catching up with the backlog of colorectal screening patients that need screening. There's a lot less exposure to family members and friends that need to come to the hospital to drive you home. There's less exposure to personnel at the hospital, and the exam is quicker. So it might be a safer alternative to colonoscopy in the COVID era. When you look at performance, I'm going to glance over these real quick, but basically it shows that there's no real statistical difference in terms of the accuracy of CTC in the detection of polyps compared to optical colonoscopy. And this has been proven as well in the multi-center trials in the Akron trial that was also published in the New England Journal of Medicine, as well as in multiple multi-center trials in other countries as well. So this is a quick case, the only case I'm going to show you of a CT colonography. And usually the interface shows you the multiplanar reformats in axial, coronal, and sagittal planes. It'll have the 3D endoluminal view that you guys have seen for virtual colonoscopies in the past. And then some vendors also have this virtual dissection view, which basically looks like a colon that's been cut along one side and opened up like a gross anatomy specimen. And then on the endoluminal views, basically, once the 3D workstation generates a center line, the virtual camera follows that center line. And you can see here in this map, it's going through the ascending colon towards the cecum. And this unfortunate individual has a 4 centimeter mass right at the region of the ileocecal valve. And then the fly through is going to go through, this is the appendix here, it's going to go through the ileocecal valve into the terminal ileum. And you can see this really long stalk for that mass, which looks like it's prolapsing through the ileocecal valve. So that's your typical appearance for a CT colonography. And in this particular case, this unfortunate patient was me. This is my CT colonography from January. And I saw this while I was on the scanner checking the adequacy of my insufflation. And I knew that I had to take a look at this exam myself. So I did I looked at my own study and called up my gastroenterology friend the same day and got myself onto the schedule 2 hours later. And he spent 3 hours resecting this mass in piecemeal, which you see here on the endoscopy image, and was able to resect it all the way down to the base of the stalk. And for a whole weekend, I was facing an existential crisis of what this would turn out to be, because the chances are pretty high that a polyp of this size, or a mass of this size, would end up being, if not a high-grade adenoma, an outright cancer. And the good news, I suppose, is that the pathology finally came back as a hamartoma, and not an adenomous polyp, although there was a tiny little 4 millimeter polyp on the cine image if you saw it. on the previous screen that did end up being real. So 45 is not too young to start getting screened. The incidence is increasing in those under 50. And if you're looking for a place that's doing CT colonography, the ACR took over this tool from Bracco recently. If you just Google ACR CT colonography locator or try or input this URL, you can find a location near you. You can see if your institution is doing it. If they're not on the list, you can also add that location to the list so they can join the locator tool as well. So in summary, colorectal cancer has the model pathobiology for cancer screening. It's the least controversial of all cancer screening options. CT colonography is an ideal screening option amongst many. CTC will increase screening rates and save additional lives, and the selective polypectomy paradigm can limit complications and resource utilization, particularly in the era of COVID-19. So the bottom line is, although I certainly am a big fan of CT colonography, I think the best screening test is the one that gets done. This is what the U.S. Preventive Services Task Force also agrees. Most gastroenterologists agree this as well. As long as you pick a test from that menu, it's better than not getting any test at all. And the most of the battle is just getting to convince a patient to get a test in the first place. And if you have any questions, feel free to ask. I can also respond to them by email. If you type them in here, I can respond later on as well, since it is 1:02 p.m. Thank you very much. And this is my email address and Twitter handle as well. And I hand it back over to Harp.
Thank you very much, Dr. Chang, for that amazing talk and your personal story, which is also as amazing. And thank you for sharing that. With that, I'd like to conclude today's session. Thanks to all the attendees, and have a great weekend. We will see you next Tuesday for our next session. Be well.